Hello to our listeners and welcome to the CardioVisual app. I am Ralph DeFronzo and I am Professor of Medicine at the University of Texas Health Science Center in San Antonio, Texas. And I also serve as Chief of the Diabetes Division. For those of you who don't know my background, and in addition to endocrinology and diabetes, I'm also board certified in nephrology. So today I'm going to wear my nephrology hat. Today we're going to talk about renal outcome trials in type 2 diabetes, implications for therapy. So it's obvious that we're going to need therapies that not only prevent the development and progression of diabetic kidney disease, but we're also going to need therapies that are going to prevent the development of the cardiovascular disease, which is already going to be well established in these individuals. So let's start with the cardiovascular outcome trials, because many of these cardiovascular outcome trials have used drugs, which are also going to be effective in preventing diabetic kidney disease. Let's start with the EMPA-REG outcome study. In the EMPA-REG outcome study, individuals who had had a previous cardiovascular event were randomized to either empagliflozin or pioglitazone. As you can see in the first panel to the left, the Kaplan-Meier plot showed a hazard ratio of 0.86, meaning a 14% reduction in the MACE endpoint, which stands for Major Adverse Cardiovascular Events. And this was the first drug to be approved for the prevention of atherosclerotic cardiovascular events in people with type 2 diabetes by the Food and Drug Administration. If you look in the middle panel, you see this really quite dramatic reduction in cardiovascular mortality, the hazard ratio of 0.62, 38% reduction in cardiovascular mortality. And then if you look in the third panel, you can see the marked reduction in hospitalization for heart failure with a hazard ratio of 0.65. Now, there have been a number of other cardiovascular outcome trials, and I'm not going to take you through each one individually, but I'm going to summarize them here on one slide. So we have the DECLARE study in yellow with dapagliflozin. We have the CANVAS study in green with canagliflozin. And what I already showed you was the EMPA-REG outcome study with empagliflozin. So let's look at the MACE composite endpoint. So as I said, MACE stands for Major Adverse Cardiovascular Events. It's cardiovascular mortality, non-fatal MI, non-fatal stroke. You can see hazard ratio of 1, meaning no benefit, points to the right, an increase in the risk, points to the left, a decrease in the risk. And you can see all three of the circles fall to the left of 1, meaning benefit. If you look at cardiovascular mortality, you might get the impression that there's a difference between the three drugs, but as I'm going to try to point out, this difference is more related to the patient population, to the drug itself. So in the EMPA-REG outcome study, 100% of the people who got into the study had a previous cardiovascular event. So they're the sickest people. So not surprisingly, you're going to see the biggest benefit in terms of cardiovascular mortality. The DECLARE study, which is the yellow dot, these were the least sick people. Some 2/3 of the people got in because they had risk factors, not because they had an event. And therefore, you see the least effect in terms of cardiovascular mortality. And the CANVAS program, these people were of intermediate risk, and you see the intermediate reduction in mortality. As you move down, if you look at non-fatal MI, all three showing substantial benefit. Stroke, there was actually no benefit in stroke from any of the three drugs. We don't really understand that to this date because these drugs all lower your blood pressure, and of course, increased blood pressure is a major risk factor for stroke. So a little bit surprising that we don't see the benefit. If you look at hospitalization for heart failure, hazard ratio is about 0.7. All three of the drugs decreasing hospitalization for heart failure by about 30%. And look at the bottom, incredibly dramatic, about a 40 to 50% reduction in a composite renal endpoint, which is halving of your GFR, doubling your serum creatinine, progression to end-stage renal disease, meaning dialysis or transplantation, or renal death. So all three of these SGLT2 inhibitor drugs are very effective in decreasing cardiovascular events. And as shown in the bottom, a secondary endpoint in all of these studies was the renal composite endpoint, all showing a renal composite benefit.